All right, so I'm going to start, and if there's any questions, then we can certainly circle back to that if someone needs. Okay, so thank you so much for joining. I am the Chief Medical Officer for the Department of Public Health, a role I've had just about 2 years. And we today we'll talk about the some common respiratory illnesses, and we'll talk a little bit, touch on tuberculosis, which is something that folks are concerned about as well, and another infection. And finally, we will spend a little bit of time speaking about the Flovent, which is an asthma management medication, but we'll spend a little bit of time on that too. I just want to make sure you're all aware of that. So thanks again so much for joining. Next slide. In this talk, I'm going to start our discussion with our current state situation, and what we'll touch on is not only kind of the viral picture where we are with the winter viruses, and then we'll also spend some time looking at vaccines, and because obviously that's the best thing anybody can do to protect themselves and their family. And then we'll circle back and go through the specific individual topics, the viruses that we're seeing most commonly at this time of year. Next slide. Great. So really what I wanted to do is just take a step back and say, you know, we all know you've probably got friends and family members who are at this point, you know, suffering from an upper respiratory infection. Potentially it's COVID, potentially it's flu. It could also be RSV. And this is the time of year that we see a significant increase in the number of visits to the emergency department, and also the number of admissions to a hospital for respiratory illness. And so what this table essentially is showing us is that, you know, week over week, so for the end of the year and the beginning of the first week of January, that we've had still pretty high levels of admissions and viral visits to the emergency department. That's 17 and 20, almost 21%. They're a little bit less than they were the week before, but they're still fairly high. So again, it's important to understand that you know, this is a pattern that tends to kind of go up and down a bit, but has been climbing for quite some time, and we anticipate it will stay high for the next several weeks to a month and a half potentially, as we're really in the heart of flu season, and then you have RSV and you have COVID, which is also significant, and we'll get into that a little bit more. Next slide. And this, one of the things that we want to stress is the importance of vaccinations. And so I want you to know that if you look at the numbers of vaccinations by for you know, in the Commonwealth, and this is looking specifically in the Commonwealth, you can look at the number by age, and you can see kind of where we are with not only COVID vaccines, which again, fairly small numbers under 5 years of age, and still real opportunity even in our over 65 age group. And then also looking at influenza, we tend to do a pretty good job with influenza across the Commonwealth, but still room to grow there and to improve. So we'll talk some more about that as well. Next slide. All right, so I thought we'd touch on RSV. This is a virus that this year, so it's RSV, or respiratory syncytial virus, and it is one of the most common viruses that typically starts in the fall and peaks in the winter. It usually causes mild cold-like symptoms. Most folks can recover within about a week or two, but it can be serious, and it's serious for those within the two extremes of life, right? So the very young infants and our older population as well. Our seniors, certainly seniors over 80 years of age, most at risk, though most believe that even into your 60s is where the risk begins higher with RSV. And so I think that's important to understand. And those are the groups that are currently being hospitalized, right? And so there's opportunity here to talk a little bit about how we protect ourselves and protect others. So how is RSV spread? It's an infection that spreads when someone coughs or sneezes. So it is in the particulate matter that comes out of the mouth or out of the nose. These droplets then can get into somebody's eyes, somebody else's eyes, their mouth, or their nose, and that's how the virus is spread. You directly contract the virus that way. You can also get it because if you touch a surface that has that someone has sneezed on. I know it sounds kind of gross at lunch here, but if there is mucus or secretions on a counter, on a doorknob, you can touch those and then touch your own face, and that can also lead to spread of the infection. So that would lead you to believe then cleaning those surfaces is important, and also hand hygiene is really important. I will say that RSV is one of the hardier viruses. And what that means is that if typically viruses don't live all that long outside the body. So if you sneeze on a countertop, and it's one of our other viruses that are very common in the body, they tend to die very quickly on those countertops. RSV will stay around unless it's cleaned off with a disinfectant for quite some time. So even up to hours. So important to think about cleaning those surfaces. Next slide. So I wanted to touch, and we're going to touch on vaccines in all three of these viruses that we're going to spend some time talking about. So there are several different RSV vaccines, and this was actually a really important year in the development of RSV vaccines. So for a long time, RSV has been around, and there has not been an effective vaccine for RSV. So this year, there's an adult vaccine that's for adults age 60 and older. This is a vaccine that may be appropriate for the adults in this group, and it's important to have shared decision-making with your provider. So not everyone over 60 needs this vaccine, but certainly if you're a high-risk individual, if you've got comorbidities, if you've got others in the family potentially that you could transmit this to, that you're worried about, then this is a good vaccine to certainly consider, and there's plenty of this vaccine available. Infants and young children. So that is another group that we think about from a vaccine perspective. And this is really to prevent severe RSV disease in these kids as well. The CDC recommends there are two options for protecting infants and against RSV. One is for a maternal vaccination. So now there's actually a vaccine available for moms in their later part of pregnancy, that 32nd to 36th week of pregnancy, which will then give them some immunity, give the infant before they're born some immunity. And so that is really important as well. And that's one way of protecting the infant. And the other way is that infants can actually receive the vaccine themselves. And we're not calling it a vaccine, it's an immunization, it's an RSV monoclonal antibody that came out strong in October, November. We had discussions about it, really excited to get it out there to anyone under 8 months of age born during the season, the RSV season. And then we had shortages of it, unfortunately, very quickly. Now, so we then had to prioritize high-risk infants, newborns that hadn't received the potential maternal vaccine. So now there is more of this vaccine available. The RSV season is continuing. We may have peaked, but it is continuing for several more months. And we're really hoping that folks will, these babies can get protected, because this is tough for babies, infants under a year of age. So either by the mom getting the vaccine or the infant getting the vaccine as soon as they're born is also really important for the next several weeks. And then there's also folks who could potentially utilize the vaccine or benefit from the vaccine for infants and young children who have chronic illness and could potentially need it for even their second season, and that's the 8 to 19 months of age, and that's the RSV immunization we talked about, nisimabab, and that would be helpful for them as well. There's hopefully more of that coming out. It was in pretty limited supply. So good news, next year will be a real difference for RSV moving forward, and hopefully we'll be able to bring the number of RSV infections and kids being admitted to the hospital and seeking help for respiratory trouble, which will be great. I'm a pediatric emergency medicine doc, so I take care of kids in the emergency department, and RSV is one of my biggest challenges. So I'm really happy that we've got something to help us with these infants. Next slide. All right, so that's RSV. Good news, lots of vaccine available. We really want to protect newborns. We want to protect those over 60, and typically the group in between, not that affected by RSV. So don't have a vaccine that's really appropriate for that age group. Flu is a different story, right? And so flu impacts everyone. It's contagious respiratory illness. It's caused by the influenza virus that infects the nose, the throat, and sometimes even the lungs. It can cause mild to severe illness and even death. There are routinely deaths every year in pediatrics and adults from influenza. And the best way to protect yourself and others against flu is by getting the flu vaccine. So, we know that flu, there's a new vaccine every year. And so it's important to remember that and to understand that every year the manufacturers and the scientists take a look at what flu variants we think we're going to have, and then the vaccine is developed to protect us. And really important to get vaccinated. And you still can get vaccinated. Flu will continue for months. It starts a little bit later in the winter season and will continue through at least March. So important to get vaccinated even at this point for folks. It is transmitted by tiny droplets when people cough, sneeze, or talk. These droplets can land in the mouth or in the face of somebody nearby. Less often with touching your own mouth and eyes after touching an object where the virus was on. So this virus is not as hardy as the RSV virus. So while, yes, we always say, because we can't tell which one is there, we want to clean surfaces, clean your hands as much as possible, avoid touching your face is really important as well. Next slide. And then I thought we would touch on COVID-19. Obviously, this is, important. It's a persistent infection that we've now known about for several years. It's spread, it's caused by the virus SARS-CoV-2. It is very contagious, really significantly contagious, and spreads very quickly. Probably more contagious than the other ones we've been talking about for sure. And the most common symptoms here are cold, flu-like symptoms, and pneumonia. But people who may have only mild symptoms, if you're young and healthy, mostly kids have very mild symptoms, but you can also have severe symptoms. And we certainly have seen pediatric deaths as well as many, many deaths from COVID as we were understanding this as a new infection and trying to manage it. Transmission here is when an infected person breathes or these droplets out. These are really tiny droplets and particulates, and they're spread very easily. Someone else can breathe them in as opposed to it landing on their face, and that's another way of contagion and how it's transmitted. And obviously, if they land someplace close to you, then that's another concern. Remember, we were talking about 6 feet distance and spacing. These were all important ways to protect yourself when we first understood COVID was a new infection we were dealing with. Next slide. Okay, so I'm going to touch, sorry, I think my slides were out of order here. So this is the influenza vaccine slide, and we want to talk about touching briefly on kind of who the vaccine, who can get the vaccine, who should get the vaccine. So it is recommended for anyone 6 months and above without any of the prior contraindications. So that's, clear as can be. 6 months and above should get the influenza vaccine. It's 1 dose for those 9 years and older is a single dose. You should get that any time in September, October and then should continue. That's ideal. But you can continue getting your vaccine for influenza up through the season. So if the season goes through March, you can continue getting your vaccine through March. So it is not too late. Vaccines are available and folks should get their vaccine. That's our message with influenza. We can really protect ourselves and others by getting vaccinated. For those in the younger age groups who've not previously had 2 doses of the of influenza vaccine, then the recommendation is to get 1 dose as soon as it's available. So for new infants and children that are new to the influenza vaccine, as soon as it's available in the summer, July, August, for the next year, they can absolutely get it. And then the second dose should be given. So they require 2 doses. Second dose should be given about at least 4 weeks later. Can be further than that, but to build that immunity quickly, 4 weeks or a month later after the first dose is when you want to give it. And there have been some recent studies looking at the 22 influenza season, which I thought was really interesting from a pediatric perspective. And this, I think, drives home why we want our children vaccinated as well. Vaccination reduced hospitalization by 40% and ED visits and urgent care visits by 48%. It was most effective in that younger age group, which is most susceptible. So that's 6 months to 4 years. If we can get them vaccinated during the season, we cut almost 50% of their need for hospitalization or visits to the emergency department and urgent cares. That's great news. So this is a selling point for you to take back to your communities and really push the influenza vaccine. And yes, unfortunately, it means next year we're looking to do the same thing, right? Next slide. Okay, so let's touch now. I'm taking a step back about COVID-19 vaccines. So everyone 6 months and older should receive the updated 23-24 vaccine. So this is where we have the opportunity to make sure that there were a lot of prior vaccines. We all know that, but the updated vaccine came out in September, and that's the vaccine that will protect against the current circulating variants, and that's what we need folks to be able to understand and to get vaccinated. It's one dose if you're 5 years or older. So again, very simple. There are multiple manufacturers, Pfizer, Moderna, right? But it's one dose. If you are from 6 months to 4 years, it may be multiple doses and at least one updated dose. So we can talk about that specifically, but that younger group, just like the flu vaccine, because they're being introduced to this vaccine anew, right? They haven't had prior exposure. They would need at least multiple doses, 2 doses at least. And then for adults and other individuals that are immunocompromised, additional doses may be required as well. That'll be something that is up to you and the patient and their provider, if they're immunocompromised, how many doses they would need. But everyone should be getting that single dose of the updated 23-24 season vaccine. And the only other thing I'd say here is that these recommendations may change in the coming years. And is there another? People ask me all the time, will I be required to have another vaccine, COVID vaccine next year? Is it going to be like the flu? Maybe we're assuming that. We don't exactly know how much protection. We know how much protection you get from the flu vaccine. We're not yet sure how long the protection lasts from the updated COVID vaccines and whether or not there will be a new vaccine in the fall. But for now, everyone should get this vaccine, and that'll really protect folks moving forward. And we can talk about the work that we have to do there a little bit in a few minutes. Next slide. Okay, so I thought, so we talked about kind of the 3 big circulating, I think last year we called it the tridemic, right? So the 3 big circulating viruses, RSV, flu, and COVID. And I will tell you that I have seen children that have contracted, while not all 3 of them, though some of my colleagues have 2 of them at least. And so, this is really hard on your body to have to protect, combat not only 1 viral illness, but 2 viral illnesses. So we really want to do our best to protect ourselves from getting those. So in addition to vaccines, what are some other strategies to prevent respiratory illness? So the one thing I'd say is if you're not feeling well, stay home, test. Right? Find out. You can certainly test for COVID at home. It's available. COVID tests are available, and so I think it's important for folks to know. Now, that's only one viral infection, COVID, that you're testing for at home, but that's still an opportunity to know if you don't want to go and transmit this to other folks. So stay home when you're sick is going to protect lots of folks around you. And if that's the message that you're telling your communities, then it's really important. It's potentially protecting your communities as well. They're protecting themselves from each other, right? So really important for us to understand that. The basics about what do you do when you have to cough or sneeze, right? So it's into the sleeve, not on the hands, because then, you could shake somebody's hand or touch a doorknob and then spread it that way. Soap and water is really important. And if you're going to use soap and water to wash your hands, 20 seconds is ideal, okay? And I know that seems like a long time, and if you haven't counted it yourself, it really is. But again, hand sanitizer works well for all of these viral infections, and you can do that. That's a much quicker option. But when hand sanitizer doesn't work, it's when the hands are soiled, and so it's really important to wash then if they're soiled. You want to avoid touching your face, and it's hard. I've probably touched my face 3 or 4 times already today. So that's something that's difficult for us to do, especially if our hands are unwashed. And then, you want to avoid close contact with others, and you certainly don't want to share eating utensils and cups and things like that. It's just during this high season of respiratory illness, we want to avoid all of that unnecessary risk. And then we talked a little bit about RSV and those surfaces and the other viral infections. Really important to consider cleaning surfaces as quickly as possible. One of the things we do in the emergency department, which I find really interesting because I never did this, in 20 years of practice prior to COVID, is cleaning my workstation when I sit down and when I get up to leave at the end of my shift, and then making sure when the new doc comes on and the new provider, they clean the workstation right after I leave, and they do it again at the end. And that's just, basics and something we probably should have been doing for a long time. But now we know that's a way to protect ourselves and protect others. And then the last thing I'd say is, masking is always an option. It is a tried and true option. You can absolutely wear a mask. And if you're high risk, a higher protective mask, one of the N95s or KN95s, is always within your right to do. And there are certainly masking. This is at healthcare facilities or have chosen to do this based on transmissions, which was our recommendation rates. And so, I do this when I work clinically. My patients wear masks in certain settings. And so I think that's really important for you to consider and feel comfortable doing that. It's your right to protect yourself if you want. Next slide. Okay, so I'm going to pivot now, and again, we'll go back and answer questions that you have, but I want to pivot to tuberculosis. And the reason that we thought we'd talk a little bit about this is this TB is not new. It has been around for quite some time, the dawn of ages, I think. But what's important to understand is that it's become more talked about, and there's more confusion because of some concerns around folks, new arrivals to the country. We've always screened new arrivals to the country. There's always been, opportunities. But as healthcare providers, we're screened all the time, even in healthcare settings. So I just wanted to make sure that we understand what we're talking about with different terminology around TB, and we can again address more questions. But TB is spread from person to person through the air. It's by Mycobacterium tuberculosis is what is the bacteria that causes it. These bacteria are germs, usually attack the lungs, though they can attack any part of the body, including the spine, the brain, the kidneys. So pulmonary TB is TB that's in the lungs. You may hear it referred to that way. And extrapulmonary TB is, those other spots, right? So the spine, the kidneys, or the brain. And not everyone who's infected with TB becomes sick, and that's where I want to talk about a couple of terms on the next slide. Next slide. So how is TB spread? So we talked a little bit about that. It's when someone coughs, when someone with active TB coughs next to somebody else. So it's the speaking, the coughing, the singing. Those are ways of it coming out of the lungs and into, onto someone else. Or it's not spread by simply, kissing someone. It's not spread if these pictures are all, by eating or sharing utensils. It's not spread in the bathroom, right? By sharing a toilet, by hand-to-hand combat, so shaking hands, or by brushing teeth. Those are not ways that TB is spread. It really has to come out of the body to be spread and then ingested. Next slide. So this is where I want to talk a little bit about the two conditions that we think about. So if you look at the bottom of the slide, TB disease is when the germs become active and multiply. So and multiply within the body, and and that's when you get the disease, and that's when folks are contagious, right? Latent TB is when and people with latent, that's it's abbreviated LTBI. It's when there's a small amount of germs within their body, but they're inactive. Those TB germs are inactive. They don't feel sick. They don't have symptoms, and they cannot spread TB germs from to others. People can have latent TB for years, right? So I think it's important to understand that that's not something new. We've known about it. We've managed it for a long time. Latent TB can become active, and that's those folks that we then need to monitor. We would monitor folks with latent TB, and if it becomes active, then we would potentially need to work on treatment and other things, and we'll talk a little bit about that. Next slide. So how do we test for TB? So there are two tests for TB. There's either the skin test, and many of you may have had that tuberculin skin test. I know I've had it for years since I was in medical school and working in hospitals. And then many of us have moved to the blood test. And so that's another way of testing. And if either of these two is positive, so they're both appropriate to screen, if either of them are positive, then we need to do more, right? So if you're positive either with the tuberculin skin test or with the blood test, a chest x-ray and a medical exam is likely what's needed. And I have, in the emergency department, been the recipients of folks with a positive blood test who came in to then get a chest x-ray. They're not having any symptoms, but we need to prove that there's no active lesions in their lungs to be able to then manage them and talk about treatment with a TB specialist. Next slide. Okay, so again, that's TB. I just wanted to be clear that there's some confusion around latent TB and active TB, and the number of active TB patients is very small, and there's great monitoring to protect individuals. And latent TB doesn't mean that they have active TB or will have active TB, so that's something else to be aware of. Happy to answer some questions there. So this doesn't necessarily, this last slide doesn't necessarily pertain to what we came to talk about today, but I wanted to use this opportunity to make sure that we get out in front of a potential issue for folks, especially during the viral season. So you all know that kids and adults with asthma, viruses can trigger them. And kids with asthma that is considered chronic asthma are typically on, even mild asthma, are typically on a controller medication, or and often many are on Flovent. And it is an inhaled type of medication. It's a steroid that helps kind of suppress the asthma symptoms, right? And it's used every day, whereas an albuterol inhaler or a treatment, right, the mask and treatment from a machine, a nebulizer, is done for treating acute symptoms. The Flovent and other types of controller medicines are done every day to manage and control and prevent those acute symptoms. So I just wanted everybody to be aware that there was, what we learned very recently is that the manufacturer of this inhaled corticosteroid is, the brand name is no longer being produced. It was discontinued as of 2 weeks ago, the end of the year, the end of December 2023. What that means is that there are other generics that are available that are not brand name. But for us as a state, we just want to be clear that the brand name was the preferred product. So many of our kids on Mass Health were getting the brand name product Flovent. Moving forward, Mass Health has given us a few months to get this together, but moving forward, there will be no longer any of that Flovent brand name. It will run out. Pharmacies may still have some, but they will run out of that supply as it's not being produced. And anybody who wants the generic Flovent will need prior authorization and probably won't be able to get the insurance company, Mass Health, to approve, and potentially other insurance companies, but we all know there are a lot of our communities covered by Mass Health, to approve this. And there are equivalents that are out there, but to get an equivalent you'll need, so it's a different product, it's not the generic, they'll have to actually get a provider to prescribe that. So what we want is, and we're working with providers, and we're going to be sending out some announcements to make sure that folks understand, that they're going to need a new prescription for this controller medication. We just don't want anybody to be caught off guard in March and not be able to get this, and pharmacies to have lots of concerns around trying to get new prescriptions from providers. So we're working with providers, we're working with Mass Health, and now we want to work with our community organizations and patients to be aware that, if they have a concern here, if they have a child who has asthma, and they're not even sure whether or not this is an issue for them or not, simply reach out to their provider and ask, is there anything I should worry about their asthma with the changes in the insurance coverage for the product they use? And that's all they need, and their provider will know exactly what it is, and they can get them ahead of time that alternative that's available and just as good. So to be clear, we do believe that the alternatives are just as good. It's just making the change all of a sudden we don't want that to all happen in March. Thank you, and happy to answer any questions. I think I need next slide. and I will kick it over to our executive office to talk about our treatment for COVID and Paxlovid.
So was just saying that my name is Tammy Siegel. I'm a Deputy Chief of Staff at the Massachusetts Executive Office of Health and Human Services. I'm pleased to be here to discuss with you the telehealth program for COVID-19 treatment. So many of you might already be aware that almost 2 years ago, the Commonwealth launched a free online telehealth program to access COVID-19 treatment, particularly 2 types of oral antiviral pills, molnupiravir as well as Paxlovid. We launched this program to anyone that is in Massachusetts over the ages of 12 years old, because we were seeing that many people were experiencing barriers and challenges with accessing COVID therapeutics. And we know that COVID therapeutics, as well as immunizations, are really some of the key tools that we have to prevent adverse events from COVID-19 disease. So I'm just here for a few minutes to tell you about the program. You can access the program when you have confirmed or suspected positive COVID-19 diagnosis. So if you test positive, you can access the program in 2 ways. You could call the phone number that's listed here. It's a hotline, or you could log in online and you'll find the link to log in at mass.gov/COVID telehealth. You will submit a few answers regarding your illness status, how long you've had COVID, what you're feeling, your medical history. And then if you're deemed potentially eligible for Paxlovid or molnupiravir treatment, you'll be connected with a doctor for a virtual visit. The doctor usually comes on within just several minutes, but at most, it'll take 30 minutes to be connected with a provider. This service is available in over 14 different languages, including Spanish, Haitian Creole, Portuguese, Arabic, Chinese, and Vietnamese. And we also have American Sign Language interpreters, as well as CART captioners, free and ready to join your virtual visit if that would be helpful. I'm so glad you had a good experience, Olga. Insurance is not required to use the telehealth service. However, when you're answering questions about your medical history and your COVID history, you will be asked if you have insurance, and if so, if you have public or private. We collect this information so we can better serve folks moving forward. We like to know about insurance status because it helps us be able to make sure that we're providing the programs in a productive way. But if you don't feel comfortable answering that question, you don't need to answer that question, and no one will be billed for this service. If we have flyers available, if you'd like to spread the word about this service to anyone within your networks or your community, they can be found at mass.gov/COVID telehealth. There's just one more slide, if we don't mind clicking forward. Thank you. Here, I just want to spend one moment to talk about some of the Paxlovid patient assistant programs that are available. So you might be aware that Paxlovid is now commercially available within the United States. So previously, before this past winter or the past few months, Paxlovid was purchased by the federal government and allocated to states and then given to patients for free. Now Paxlovid is on the commercial market, meaning that it is now considered just like any other type of drug that you would access at your pharmacy and have to use your insurance or pay out of pocket to leverage. Paxlovid can be really expensive if you don't have insurance or if you have a high copay. So there are 2 programs available created by the federal government to provide Paxlovid at no cost to the patient. These programs are listed here. So you'll see that the USG, which stands for United States Government Patient Assistance Program, is provided by Pfizer, and those are for Medicaid, Medicare, or uninsured patients. And then another program is for those who are commercially insured and would like financial support to cover Paxlovid treatment. I'll just close by saying that I forgot to mention, but this program does include free overnight delivery 7 days a week. So if you get prescribed Paxlovid, then we will ship the medication to you anywhere within the state, free of charge overnight. And this program is available 7 days a week, even on New Year's and Christmas. So thank you for the opportunity to tell you about it. And I look forward to answering any questions if you have any. Thank you.
Thank you so much, Tammy, for joining our webinar and sharing this very important information about this program. I hope this is very helpful. And again, this is information that we will share. We will send out to all participants in a package that we'll be sending out after the webinar. Thank you. And then I'll pass it on to Dr. Garcia and Gwen. Both will be going through the questions.
Great. And I think we can probably remove this slide. Thank you. And while we're getting the questions set up, I just want to say that, so I also am one of the lucky Paxlovid recipients, and it was amazing, quick. I mean, I called my provider who said, well, you have to come in and see me, and we have to do all of these steps, and, that's the last thing I wanted. And so we did it over the phone. I got it very quickly and was better in 48 hours. And I'm ever grateful for that service. So please make sure folks are aware and utilizing it. So thank you.
Thank you. So glad to hear that.